Hi everyone, thanks for joining our webinar. Our topic today focuses on the essentials of CBCT, what images to capture and when. My name is Adam, Content Marketing Specialist with Henry Schein, and I'll be your moderator. There will be no live Q&A following today's presentation. If you have additional questions about CBCT that can't be answered by today's presentation, please send us a question via the chat tool and we will get an answer to you as soon as possible. This webinar is sponsored by Henry Schein Dental and Cavo Imaging, and no CE credits are being offered for viewing this presentation. Our speaker today is Dr. Katya Archambault. Dr. Archambault is board-certified oral and maxillofacial radiologist from UCLA and clinical instructor for the Surgical Department of UCSD. Before I hand it over to Dr. Archambault, I would like to note that some images in this presentation are graphic. Please be advised.
Good morning, everybody. I want first to thank Henry Schein for having me this morning, and Adam and Andrea. So I'm very pleased to be here with you. My name is Dr. Katya Archambault. I'm a board-certified oral and maxillofacial radiologist and diplomate of the American Board of Oral and Maxillofacial Radiologists. I work here in La Jolla in South California at UCSD, where I'm an adjunct faculty in the head and neck surgery and otorhinolaryngology and plastic surgery. So we are here on the UCSD campus. You can see on the screen the UC San Diego Jacobs Medical Center. Our offices are in that building, so it's a very modern hospital. I work with a maxillofacial prosthodontist, and we are in the San Diego Dental Health Center. So I did my pre-dental school in Laval University, and I did the dental school there as well in Montreal, Canada. I'm also trained in surgery from NYU, and I did my oral maxillofacial radiology at UCLA. I also did a master's degree in Austria on TMJ. And I'm here and I work principally with head and neck patient, being in the head and neck department. So you see my email address. So feel free to email me if you have any question after the webinar. And you also can visit my Facebook page, which is Dr. Katya Oral and Maxillofacial Radiology. So I create some posts and I give regularly information. There's also webinars that you can attend there on different subjects. So feel free to interact with me. I like to teach, so there's a lot of information on that site. So I'm going to start with my first case. Being also trained in surgery, I see patients as well as doing radiology. So I'm like you. So I have a practice where I see real patients, not only a radiograph. So I want to start with that case, a male of 57 years old that had no particular finding on his medical or dental history, other than he did not visit any dentist in many, many years. And he wanted to have a second opinion for probably rehabilitation and some implants. And he came to the office. So here is an extraoral picture of the patient. He wanted to improve his appearance. That was his main concern. So you have a intraoral picture of his failing dentition. We can see that he demonstrates edentulism on both aspects of it, the mandible and the maxilla. And here is an occlusal shot from the maxilla. So you can see that the teeth are in pretty bad shape. So that was his panoramic radiograph. So you can appreciate the edental area. So I'm letting you look at that panoramic radiograph as well, because I like to make the webinar interactive as much as we can, even though if this one is pre-recorded. But when I give that to a real audience, you know, I ask them questions. I want you to ask yourself, would you extract everything, place implants on the maxilla and on the mandible, like all on four type of restoration or rehabilitation? Will you keep some of the teeth and crown them and do removable, or just place implants in the edentulous area, for example, from teeth number like 2 to 5, and then on the other side? So think of the treatment plan you would suggest to that patient. And the also very important question that I ask is, would you take some more radiograph to be able to treatment plan accordingly with implant surgery, or would you go ahead just with a panoramic like this one? And then we'll go to the second case also that you could see in your offices. It's a perfectly healthy 27 years old male, had his FMX 6 months ago. So the question I'm asking is, okay, would you take some more radiograph? Would you go with a panoramic radiograph in that case, or you would just reschedule the patient according to the ADA recommendation and take other intraoral radiograph in 24 to 36 months, being a patient that doesn't demonstrate any large restoration, seems to have a very low risk for decay? So what would be your recommendation for that patient? So when we think as a radiologist, we have 3 major guiding principles. The first principle is justification. Basically, justification is telling you that a dentist should identify the situation where the benefit to the patient from the diagnostic exposure, okay, to radiograph, when you're taking your radiograph, is exceeding, the benefit exceeds the risk, okay? So it means that if your clinical exam doesn't give you all the information that you need, okay, to do the proper treatment plan, or to assess if you're looking, for example, for a root fracture, or if you're looking for something very specific, are you seeing this in your clinical exam, or you don't? So you're then justified to take some more information, which most likely are going to be furthermore radiographical examinations. So you will be then asked to optimize, which is a second guiding principle. You have to do optimization, which means that you're going to choose, for example, if you're looking for a root fracture, you're going to choose a radiographic exam that will give you and answer you that specific diagnostic task. So we know that it's very difficult to assess a root fracture on an intraoral radiograph, for example. You'll probably need a small field of view with high definition and high resolution CBCT, for example. So you'll have more chances to be able to assess, is there a root fracture or is there periradicular bone loss? That will give you a good sign of a root fracture as well. So you have to choose the good radiographic exam. And also the third guiding principle is that you have to limit the dose exposure to your patient, meaning that you're going to try to find the exam that's going to give you the most information and that will expose your patient to a minimum of radiation. So those are the 3 major guiding principles that we use in radiology, because we follow what we call the ALARA principle, which is as low as reasonably achievable. Okay? So for the case number 1, you see here that there is a CBCT that was taken from the first doctor, and you see that some measurements were made where he wanted to place probably implants. So you can see that there were measurements made in the area of teeth number 2, 3, 4, and 5. And you'll see also, if you look carefully, that there is measurement in the anterior area, okay, to assess the amount of bone available there for the future implant sites. And then same thing on the posterior maxilla. So some measurements were made. And I cannot stress enough the fact that you really need to look at the whole scan volume. So this applies for CBCT, but that also applies for any radiograph that you're taking. You are responsible to read and to assess everything that you see on a radiograph, even if it's a 2-dimension radiograph or a 3-dimension radiograph. So in that case, okay, and don't feel bad, because as dentists, we are trained and used to look, especially if you're going to place implant. Where's the bone? Where's the floor of my sinus? Where's the mandibular canal? Do I have enough bone? And we look at teeth, okay? Is there any fractured root, or is there decay? That's what our brain guide us to. So it's very important that you look at the whole volume. So in this case, okay, the patient had surgery, but and I will go over that with you. But the surgery that he had will probably surprise you a little bit. That's what the patient had. So when I received the scan, and even though when I looked at the pan at that patient, big red flags were raised in my mind. And I'll show you why. And that's why we are here, oral maxillofacial radiologist, because we're trained to look at the radiograph. So on that panoramic, and those are the implants that he had. He had like a zygomatic implants placed because he had to have a major resection. Because that patient, if you look back on the panoramic here, okay, you can assess pretty well the mandible, the condylar head, the conoid process. Then if you look at the maxilla, and you stay away from looking, okay, this tooth is fractured, obviously needs to be extracted, that crown is broken down, only the tooth is remaining there. You have to look at all of the anatomical landmark. And some of those landmarks in the maxilla are especially where is the medial wall of the sinus, especially on the left side. And even though on the right side, it's very difficult to assess. Where is the floor of the nose? It's nowhere to be seen. So when you have a major landmark that is missing from a radiograph, even on a 2D, something's going on there. Something very serious, that means trouble. Okay, so the floor of the sinus is not visible on the pan. The left and the right medial wall of the sinuses is not seen as well. The floor of the left maxillary sinus is very difficult to see. Okay, you can see pretty well in the edentulous area of teeth number 1, 2, and 3 that you see that white sharp corticated line, which represent the floor of the sinus, but it's very difficult to see that on the left side. So those are big red flags. Okay, that means trouble. And if you look back on one of the slides that where measurements were made, this one is still on the right side of the maxilla. You can assess that there is also a lot of thickening within the sinus and within the nasal fossa. So you see that thickening of the mucosa. You see that there is disruption of the floor of the cavity, and there is erosive changes that are occurring there. Okay. It means that the floor is disrupted. There is also lytic changes occurring in the area of tooth number 6 in the apical area, you can see. And there is no periosteal reaction. Usually, if you have bone loss or lytic changes, as we say, it means that if it's from an infection, you're going to have some kind of reaction from the body, Okay, the human body is pretty well engineered, so it will try to protect or isolate itself from the aggression, okay, which in this case is an infection and bacteria. So you will have some periosteal reaction. The periosteal reaction will be such as in inflammation. So you will have some bone produced, you will have thickening. Something is going to tell you, well, there's an infection in there and the body is trying to react. Well, you don't see anything like this here. You have those lytic changes, but it's so aggressive that the bone doesn't even have time to react. So that means very serious problems are going on. And in that case, after biopsy, the patient was diagnosed with squamous cell carcinoma of the nasal cavity. And you can see here on that sagittal reconstruction that there is a thickening, of course, within the nasal cavity. You can really appreciate that the floor of the nose is disrupted. If you look at the hard palate in the anterior half of the hard palate, you can see that there is erosive changes and there is no periosteal reaction there. And you can even see erosion within the anterior cranial fossa. So the malignancy was extending from the alveolar process of the maxilla all the way up to the frontal sinus, eroded also the nasal bone and the floor of the anterior cranium. So that's why you saw that a large resection was made, the whole nose basically, and that was a very long surgery with 4 teams, and the patient stayed for like 18 hours in the OR. So those are very aggressive cancer. And that squamous cell carcinoma is the most prevalent head and neck cancer. So it is something that you have to look very carefully on the pan. It was not that easy to see. And on the scan, well, you have to look at the whole thing and assess all of the structure. So that is the patient post-op with the oral and maxillofacial prosthesis and the packing. And that is the after, 2 weeks after the surgery. So those are not the before and after you want to have in your practices. So always keep in mind that head and neck cancer are part of the journey. So always be very aware and try to assess the whole volume, because unfortunately, that is something that can happen within your career. You can face one of those cases. So the second case also, of course, the question that I asked, when would you do the next FMX for a patient like this? When the risk of decay is very low, we know that for adult dentition, we will take FMX every 24 to 36 months. But in that case, on that FMX, that was taken 9 months prior to the patient symptomatology, you can also see that on the left side of that FMX, even though if you don't have a panoramic, you're still seeing enough of the sinus floor area to see that it is missing also in that case. So if you look on the right, you see in the apical area of teeth number 2 and 3, you can see that very nice corticated white line, which represent the floor of the sinus. And in the apical area of teeth number 4 and 5, you can also see that white, crisp, corticated structure there, which is more the floor and the median wall. But it's impossible to see those structure on the left aspect of the patient. That should be there in the apical area of teeth number 12 and 13, which it is not. So again, means trouble. Why the floor is not well defined there. And there is opacification also, but it's difficult to assess the opacification on that exam. I will agree. But when you see that the floor of the sinus is missing and you see opacification within the soft tissue, well, then again, raise a red flag that needs to be well assessed. And in that case, it was again a squamous cell carcinoma after biopsy. of the left maxillary antrum. So always look for all of the structure. When I give the presentation, I always have one hand that raised in the crowd, and the doctor is asking me, well, if the patient had a sinusitis, for example, would that be the same image? Well, no. The floor of the sinus will still be there, even though if you have acute or chronic sinusitis. Those structures never disappear. They are there. You will see opacification within your membrane. You'll see mucoperiosteal thickening, as we say, but the floor would still be there. And that is the MRI of that young man. 27 years old, perfectly healthy. And at that time, at that FMX time, he had no symptoms. So it went back, and 9 months after, it's always the same story. When squamous cell carcinoma or any malignancy starts within the maxillary sinus, the patient don't really have any symptomatology. And then when the mass gets bigger, they start to feel like a little puffiness within the face. They feel like stuff. And they go usually to their family doctor, get some nasal spray, some sinus medication, sometimes antibiotics. And then the symptoms don't go away. And then that's the patient 9 months later. And that is MRI. So you can see that there is hyperintense signal, like we say, and you can see that the two orbits are very bright on that exam, which is a T2. So the fluid or the CSF will be bright, and you can see that there is a hyperintense signal within the left sinus, extending from the crestal area again to the floor of the left orbit. Then you can appreciate that the left orbit is also positioned inferiorly. So the floor had some erosion, so the orbit is losing its support. So the eye is starting to sink in. We call that enophthalmia. And you can also see that the left aspect of his nose demonstrate erosion too, and the inferior concha is missing, as well as the medial concha or turbinate. So the cancer had a free empty cavity, so was very happy and could expand and get bigger because it doesn't face not too many resistance from the surrounding structure, and those can get pretty large. And that is the bone graft that was made to reconstruct the alveolar process in that case. And you can see here that the patient, after the resection, demonstrate loss of support in the mid-face area. He also had to have a surgery to rebuild the floor of his orbit, and he lost many teeth. So the first time that I saw him, that's the first thing he told me. I never had a decay, went to the dentist twice a year all my life, and I lost all my left teeth to cancer. So those are very easy to miss. Don't feel guilty. That's why I teach. And that's why I'm going to give you the information at the end of the webinar we do a mini residency here at UCSD. It's a 3-day lecture where I show you how to assess everything on a panoramic or intraoral radiograph, and on CBCTs also. So you have a checklist where you can check all of the structure, and you won't miss any of those. And always keep in mind that diseases are there on 2D. They're not going to appear on a 3D. So sometimes I have doctors that tells me, I'm afraid to take a 3D because what if I don't see a lesion? Well, the lesions are there on 2D. It's just that they are more difficult to assess, but you're still, you still need to look at the whole radiograph. So sometimes it's a very good help. And I work with the unit that I have here at UCSD is Kevo OP3D Pro. So it gives me the opportunity to take a panoramic radiograph if I need to, and also to take different field of view CBCT. So there's a lot of unit out there that you can choose, and you can still have your panoramic images in 2D, and you can also, if you need to see more in detail, and I'll go over all of those indications later in the slides, for CBCT small field or medium field, or even if the unit is letting you taking a larger field of view. So there's a lot of limitation on two-dimension radiograph, okay? I'm going to stress the fact that CBCT is not going to replace the whole imaging as technology. You still need to take some intraoral radiograph, and one of the indication for that is if you want to assess, for example, decay or caries. Well, the best exam is still a bite wing for those purposes. Okay, you will still need to have intraoral radiograph for assessing the level of interdental bone in perio, for example. Those are the two major indications for intraoral radiograph. But other than that, more and more indications are coming with the CBCT, small field of view, and I'll go over a few of those. If we think endo, for example, if you look at the American Association of Oral and Maxillofacial Radiologists and the American Association of Endodontics, they published a guideline, and I will make those information available on my Facebook page. So go again, Dr. Katya, Oral Maxillofacial Radiology, and you'll have those guidelines there. So for endo in 2016, they published a nice paper where all the indications for small field of view are described in details. For example, if you have a patient that has a radiolucency at the apex of a tooth, you will need, like in this example on that slide, in some studies, you'll see that you need 30 to 40 and even sometimes 50% of bone loss before you'll see the radiolucency on a PA. So that's why in those indications, let's say you have a patient, you don't see anything that attracts your eyes on the PA that you just took, and he demonstrates atypical symptomatology. Well, it's a good idea to take a small field of view CBCT to be able to assess, is there anything going on? And keep in mind that on 2D, sometimes you'll need to have tremendous amount of bone loss before you see a lesion. And it's all about the physics and geometry. And if you think of the radiologic beam, you see on the left aspect of the screen that if the beam is at an angle, okay, while it's crossing the mandible, for example, well, the apical third of the root is going to obliterate the radiolucency. So you won't see any problem, but there is. So the sensitivity and specificity on a CBCT is a lot more than on PAs. And here's a nice example where you see here a periapical radiograph of the area of teeth number 14, 15, and 16. And that's the same exact patient on the right aspect of the screen, where you see that there is large radiolucent lesions associated with the mesial roots of teeth number 14 and 14. And you see on the apex, the mesial apex of tooth number 15, that there is a large radiolucent lesion pushing or displacing the floor of your maxillary sinus superiorly with the radiodensity of soft tissue. Look like a radicular cyst, but of course we need a biopsy to do the final diagnosis. But definitely there's something going on there, and there's a radiolucent area as well on the mesial apex of tooth number 14. And if you look at the axial reconstruction, you can see that those roots demonstrate a MB2 canal, and you see on the axial view and on the sagittal reconstruction that there's no radiographic filling material. There's no endodontic filling material, that we can see within that MB2 canal. So that's probably why there is still remaining disease associated with those endodontically treated teeth. And you can see any of that. It's very difficult to assess on a PA. Well, it's obvious on the CBCT. So don't be afraid. Like I said, diseases are there on 2D. Sometimes they are impossible to see because there's so much overimposition on a PA or on a pan. But if you take a CBCT or a 3-dimension volume of the area, you might be able to see so much more. And this is a nice example also of the geometry associated with the panoramic radiograph. So on a pan, if the patient is malpositioned within the unit when you are taking the radiograph, well, you'll have distortion, you'll have area that will be very blurred and will be difficult to assess because you won't be perfectly aligned with the focal throat. This is going to be solved with a CBCT where you can manipulate and reorient your data so you can redraw the focal throat. But on a 2D panoramic radiograph, it's impossible to do so. The also very important thing to remember is that a panoramic radiograph is not a good exam to assess the length for future implant sites. So it's not a good radiograph to treatment plan implants because also, again, like I showed you a few slides ago, if you have a radiolucent area, you know, the angulation of your beam might make it impossible for you to see. And same thing for the mandibular canal. Let's say you see on the image A on the lower aspect of the screen, if the mandibular canal is lingually positioned and you see it on the B, it will look a lot more inferiorly positioned than it is in reality. So you can assume in that case that you have, for example, 13 millimeter to place your implant, but in reality, you have 10 millimeters. So it might end up with very serious consequence for your patient, such as numbness or injuries of the mandibular canal and of the nerve. So you don't want that. So it's not a good exam for treatment planning of implants. And basically, that's an image that I like. It really demonstrates what is a pan exactly. It's like spreading the whole skull on a piece of paper. So you take a 3-dimension object, which is the cranium, and you spread it on a sheet of paper. So that's why you will see that you have 2 spines and you have 2 hyoid bones. Everything that is located within the center of your cranium is going to be imaged twice. And that's the way that the panoramic works. So you'll have area of the mouth that will be imaged twice, everything basically that's in the middle of the cranium. And then you'll have also ghost images. So there's a lot of overimposition, and especially in the anterior maxilla with the nasal septum and the anterior nasal spine, you have so much overimposition that sometimes it's very difficult to assess. For supernumerary teeth, for example, in that area, sometimes it's almost impossible to see them on a pan, especially if the patient is also malpositioned and you have overimposition of the hard palate over the apical area of your maxillary teeth. So there's a lot of distortion and a lot of overimposition. Here is an example of another 2-dimension radiograph, which is a cephalometric radiograph here. And this is a ceph of a young patient. And kids are funny. Sometimes they like to stick objects within their nose. And in that case, that kid placed a penny up his nose, and you'll see the same patient on a pan. So he did not double his investment. He's still worth 25 cents, but it looked like it on the pan. And that's just like I said, everything that will be centralized within the cranium will look will be imaged twice. So here it looked like there is 50 cents in there, but no, there is still 25. And it's still a good exam to assess, for example, for a jaw fracture, or to see where the third molar are, if they are present, are they impacted? And but there is so much now indication to take CBCT, and I go over that in my webinars. There's a lot of webinars available that you'll see on the Facebook page. So I go in detail, but panoramic is still a good exam. For example, if you're suspecting a large lesion, or if you have extensive dental or osseous disease, that can be useful. The tooth development, eruption, if you have retained teeth or root tips, if you have TMG pain, that's a good exam. But like I said, there's so much indication now, and you'll have so much more detail with the CBCT that in some case you will go straight to the 3-dimension and skip the pan by itself. Okay, so let's talk about the electromagnetic radiation scale. So how are we able to take radiograph? Well, it's thanks to the X-rays, okay, that have a small wavelength and very high energy, and can go through the osseous structure and make an image on a film or on a sensor. So the only electromagnetic radiation that are able to induce damages to your DNA are basically the UV, the X-rays, and the gamma rays. Okay, and how do they interact with the matter? Well, some will have no interaction at all. They will just go through the head of your patient and straight onto the sensor, and those account for 9%. So that will give you the black aspect of your radiograph. And then others are going to be completely absorbed within the patient's head. If you have high density structures such as amalgam or implant, they will look completely opaque on the film, because the rays are going to be completely absorbed. And then you have everything else, which are the Compton scattering radio rays that will be just diverted. Basically, they will hit, like here, the chin of your patient, but they will appear superiorly or inferiorly positioned on the sensor. And that is what we call noise. So there is exposure of your radiograph, but it's not real location of the structure that was exposed. And you have also the coherent scattering, 7%, which will just be absorbed because those are low energy ray, and they will just be completely absorbed, and they contribute to the patient dose. So are we right to be afraid of radiograph? Well, the answer is yes, because it can create damage to the DNA. Is it the only thing that can create damage? No, if you're exposed to any polluting agent, and in the daily life, we're also exposed to radiation. So you don't necessarily only need to go to the dentist or to a nuclear medicine to be exposed to radiation. There is radiation in our daily life, from the air that we breathe, from the ground, from the food that we eat. We are exposed. But the human body, like I said, is a very well-engineered machine, and we have mechanisms that are able to fix or repair those damages. But when a patient is telling you, I'm afraid to take a CBCT and be more exposed to radiation, what are they referring to? There is two major effects of radiation. The first one is what we call deterministic effect. The deterministic effect of radiation basically is what we use to treat cancer patients. So we know that if we give 66 gray of radiation to the head and neck area, for example, that will be fractionated into 2 grays 5 times a week over 7 weeks, for example. And with technology like IMRT, intensity modulation radiation therapy, to the cancerous area, we know that we will kill the cancer cells. So we have a dose and we have an effect, okay? And we won't have the effect if we don't go over that threshold. that dose. So we know that after 20 gray of radiation, patient will start to develop mucositis, for example. They won't develop that at 10 grays, but they will after 20 gray. You have a dose and you have an effect. And we have the other aspect of radiation, which is what we call stochastic effect, which is why the patient are right to be afraid, but because you don't have a dose or a threshold, and you can have an effect, but it's more related to the amount of exposure. So let's say, for example, I like to give that as an example. When patients are afraid of radiation, I tell them, okay, let's think it's very sunny outside and you don't have any sunscreen, none, and you go for like 10 seconds in and out of your house. Can you develop a sunburn? Well, you're very not likely to develop sunburn because you've been out for at least not even 10 seconds. But are you absolutely sure that you won't get a sunburn? Well, the answer is no. You cannot be 100% sure. There's still a risk, but it's so little that you would not worry. So that's the same thing with everything what we do in dentistry. When we expose our patient to radiation through dental radiology, the amount of exposure is so little that it's like going outside for like 5 seconds in a sunny day. So we all agree that if you spend the whole day with no sunblock on the balcony, you're more prone or you're more likely to develop a sunburn because you spend so much time there. So you have a huge amount of exposure. So the chances are higher. But in the diagnostic dentistry, the doses are so little. We know, for example, from studies that it takes 100 microsievert of exposure before seeing an effect on a human. 100 microsievert of exposure will be like 14,000 PAs. So I don't think you'll reach that amount ever. So the doses that we use are very, very little, and I'll give you some example in a few minutes. So like I said, there is natural sources of radiation exposure. You see here on the slide that you have natural sources of exposure, and of course you have here medical source. So we say that average a year it's around 6.2 microsievert if you live in Colorado, because it's higher on the planet. You'll have a little bit more exposure, you're closer to the sun. And here on the right aspect of the screen, you have comparison. Let's say a panoramic is around like 20 microsievert, and small field of view, CBCT, will be around like 50. And I like to give example. Let's say you have to take a small field of view, CBCT. It's about the same amount of radiation that you will be exposed if you take a flight back and forth from LA to New York. So if you are going to give free tickets to your patient, I think they will all accept that and will be very happy to go spend a weekend in LA, or vice versa. If they are in LA, go spend the weekend in New York. But they would not even ask you about radiation exposure, but there is. So when you take a 5-hour flight, it's around 25 microsievert of exposure. So it's very little. And if you need the information, well, just go ahead and take your exam, because you'll see a lot more in detail whatever you are looking for. If it's a root fracture, external resorption, internal resorption, if it is to assess where exactly the mandibular canal is positioned prior to implant, you really have to have that exam. And here is the linear non-threshold model that we use in radiology, which tells you that basically below 100 milligray, which is where we are with our dental exam, we're very low on that scale, that there is no known radiation damages known. So that's a nice table. here from different dose again of dental radiology. So you see that a small field of view CBCT is around 50, like I said, medium around 100, and large around 120 microsievert. And if you take full mouth series, for example, and you don't have rectangular collimation, you use circular collimation. How do you know if you have rectangular? Well, the shape at the end of your cone should be rectangular. Or you can add, there is some units or pieces that you can add on your cones that will make it rectangular. But if you are taking full mouth series without, you are exposing the patient up to 177 microsievert, which is a big dose when compared to small field of view CBCT, for example. It's almost like 4 times more radiation. So sometimes we underestimate the amount of exposure we give with regular 2D images that we're taking on a regular basis in our office. So CBCT, it's not that much more if you're using circular collimation. And of course, CBCT are going to give you a lot of information. You can choose between different field of view, like I was mentioning before. You can choose with large, medium, and small field of view. And it's always a give and take in radiation. So you get something, you lose something. So if you take, for example, smaller field of view, well, you will have a lot more of resolution. So you'll be able to assess a lot more details. Okay, but of course, you're going to cover less anatomy, and the radiation dose will be less as well. So always keep in mind that you have to look at the whole volume. So try always to take the smallest field of view that you need for whatever you're looking for. And again, here I like that table where it shows you that basically FMX can be pretty high up here in comparison with limited, medium, and large fields of view. And then all of these examples are clinical application on CBCT. So if you're planning implants, that's a must. You should really consider to have a CBCT view of because you need to see in three dimension the area where you're going to place your implant. If you want to extract impacted wisdom teeth or impacted supernumerary teeth, it's a very useful exam. You can assess where are the surrounding teeth. And if you're looking for trauma, it will give you very good information for root fracture. Endodontics, there's a lot of application to assess the TMJ. Also, it's a very good exam because we know that panoramic is not going to give you that much information. So small or medium field of view for TMJ are very good exam. And if you want to assess your sinuses, here is an example of a case, and that's the radiograph pre-op. So again, treatment plan was done on PAs and on PAN to place implants. So that is the patient after the implant surgery. So the surgeon did nice on the left side of the patient, placed 3 well osseointegrated implant, and did a bone graft on the right aspect of the jaw, ramus graft that osseointegrated very well as well. But when he placed the implant on the right side, the mandibular canal was coursing more lingually, unfortunately. And those implants, the apical part of the implant did damage the mandibular canal, and the patient experienced some numbness. So I always say, if you don't have a CBCT for your implant surgery, unfortunately, somebody else will have a 3D view of the area sooner or later, and you really don't want to be in that position. So that patient had numbness and paresthesia after the surgery. So that's not something that you want to happen. So always stay safe and take a CBCT when you're doing implants. Dental impaction as well. It's a very good tool to be able to assess how much bone do you have at the apical area of an impacted number 17, for example. How thin is the lingual plate? How close is the mandibular canal from the apices? So there's a lot of indication also for CBCT and wisdom teeth extractions. And again, that is the recommendation here from the American Association of Endodontists, where you see on the superior aspect of the screen, on that PA, tooth number 13 was symptomatic, and you can't see anything that goes wrong on that tooth. You would probably go ahead and start the root canal therapy, but a 3-dimension view was made of the area, and you can see that that tooth number 13 demonstrates, in fact, some serious issues. There's a lot of things happening in there, internal resorption, extending from the occlusal aspect of the crown all the way to the mid root level. There is also a nice frank fracture line visible on the lingual aspect of the lingual root. And you have periradicular bone loss also on the palatal aspect of that palatal root. So that tooth is not a very good candidate for root canal therapy. The prognosis is pretty low, so an extraction would be a better choice in a case like this. So you can avoid starting root canals and have patients that are still symptomatic. If you have like a 3D view of the area, sometimes it will give you a lot of information of the root anatomy. Is there any resorption? Is there a fracture? So there's a lot of indication, of course, for CBCT in endodontics. And this is my email address again, and you have my phone number. The next 3-day mini residency that we will give here in UCSD, and you have UCSD credits for it. It's like 19.5 credits. It will be October 15, 16, and 17, and I go over those 3 days, and it's very interactive because, like I said, I am clinical, so I have real patients, so real situation that you will have in your dental office. So we go over the anatomy, of course. So we go in very much detail. You'll have a checklist of everything that you need to look at on the different field of use and even on the pan. And I also go over how to reorient your images, how to manipulate your DICOMS data, how to manipulate different software viewers that you have on different units. So you'll be able to make nice images for a treatment plan presentation or for education or for your referrals. I go also over all the indication for implants, how to make the measurement, how to do guided surgery with the information you get from your CBCT. We go over the endodontics application, how to recognize a root fracture, how to what are the radiographical signs you will have. We go over impacted teeth extraction, how to make your image, how to draw the nerve. We also go over sleep apnea, how to measure the airway. Of course, CBCT is one of the tool that you can use, but it's not the diagnostic tool to diagnose sleep apnea. You need to go to a sleep study test, and you need to consult with sleep medicine, of course. And but you can measure airways on CBCT. And we go over also the indication for supernumerary teeth and orthodontics. We go over the TMJ application and the most common incidental finding that you will find on CBCT, the one with low clinical significance and the one that you should be addressing. So you'll learn a lot. I also give a 1-day program regularly, so stay tuned. and go on my Facebook page where I always announce in advance where I'm going to lecture, and I also give a lot of information regularly there. So I hope that you did enjoy the webinar. Feel free to ask me any question. You can email me or you can message me on the Facebook page. And again, I want to thank Henry Schein and Adam and Andrea for having me this morning. And I hope that it was interesting and that you enjoyed the last hour with me. So hope that everybody stays safe, and hope to see you all soon. Bye-bye.
Thank you, Dr. Archambault, for being with us today and presenting on the essentials of CBCT imaging. And thank you, everyone, for attending today's webinar. As a thank you for attending this presentation, you will all be receiving today's recording in the coming week via email. On behalf of Henry Schein and Cavo Imaging, thank you, Dr. Archambault, for a great webinar, and thanks again to all of you for attending.